ازاي؟ يلا فكري. انا هشتغل باللابتوب بتاعي. انا هو جاهز اهو. وعايز اوصل كهرباء. في كهرباء قريبه ولا لا؟
هذا بتاع المايك. لا حضورنا الكرام، دقائق وحنبدو بإذن الله أو حنستكملوا الحدث لليوم، فالرجاء من الجميع التوجه للقاعة.
عايز الوصل بس.
حضورنا الكرام، الرجاء من الجميع التوجه للقاعة لاستكمال باقي محاضراتنا لليوم. حضورنا الكرام، قاعدين ننتظروا في تواجدكم داخل القاعة لاستكمال باقي المحاضرات في برنامجنا لليوم. الرجاء من الجميع التواجد داخل القاعة. السلام عليكم ورحمة الله تعالى وبركاته. أهلا وسهلا بكم حضورنا الكرام، ضيوفنا الأعزاء. نورتونا أكيد في ثاني أيام المؤتمر الدولي لجراحة المناظير النسائية في ليبيا في نسخته الأولى، اللي ضم نخبة من الأطباء الدوليين من مختلف دول العالم. نرحب بكم مجددا. يا ريت بس الجميع يكون متواجد داخل القاعة، لأن عندنا محاضرة بعد شوية أكيد حتكون مع عدة دكاترة، فالرجاء من الجميع التواجد في الداخل. نرحب بكم مجددا ضيوفنا الكرام في اليوم الثاني على التوالي للمؤتمر الدولي لجراحة المناظير النسائية في ليبيا. زي ما قلنا لضم عدة دكاترة وأطباء أخصائيين من مختلف دول العالم. طبعا شاهدنا من شوية البث المباشر من خلال الشاشات مع الزملاء الدكاترة. شفنا اللي حسينا فعلا ان احنا متواجدين داخل غرفة العمليات. جهود تشكر بصراحة لكل الأطباء اللي كانوا متواجدين اليوم في مركز مصراتة الطبي، واللي كانوا موجودين أيضا داخل القاعة. كل الشكر والتقدير لهم. العمليات هذه كانت الأولى من نوعها داخل ليبيا، فنشكرهم أكيد جميعا ونشدوا على ايديهم ان فعلا المجال الطب في ليبيا قاعد يتطور وقاعد يتقدم بشكل كبير. طبعا هذا الحدث لا ننسى انه هو برعاية مركز دعم وتطوير الخدمات العلاجية. حنشوفوا مع بعضنا بعد شوية هذا الفيديو اللي يوضح خدمات هذا الجهاز، وبعدها حنرجع أكيد نستمر في فعالياتنا وفي محاضرتنا لليوم.
جهاز دعم وتطوير الخدمات العلاجية جهاز مستقل تم إنشاؤه بقرار من حكومة الوحدة الوطنية، يهتم بمجال الرعاية الصحية للمرضى بالداخل والخارج، ويعمل على أن يكون أيقونة لتنظيم ملف العلاج في البلاد وداعم للمستشفيات والمراكز الصحية العامة في كل ربوع البلاد. بالتعاون مع كوادرنا الوطنية ومن خلال الاستعانة بخبرات عالمية ومن خلال مشروع عودة الحياة بتوطين العلاج الذي أطلقته حكومة الوحدة الوطنية، عمل الجهاز على تنظيم وإجراء العديد من البرامج والكشوفات الطبية والعمليات الجراحية بتقنيات حديثة، ناهيك عن الحملات التوعوية وتدريب الكوادر الوطنية ليوفر على المواطن تكبد عناء السفر ومصاريف العلاج، ولتنعم مستشفياتنا بتقديم خدمات ذات جودة عالية.
زي ما شفنا مع بعضنا مشاهدينا وأيضا حضورنا الكرام، هذا الفيديو التعريفي عن جهاز دعم وتطوير الخدمات العلاجية.
جهاز دعم وتطوير الخدمات العلاجية، صحتك تهمنا.
زي ما شفنا مع بعضنا حضورنا الكرام، هذا الفيديو اللي يوضح خدمات جهاز دعم وتطوير الخدمات العلاجية وما يقدمه من خدمات. فكل الشكر أكيد لجهاز دعم وتطوير الخدمات العلاجية، وأيضا لكل الرعاة اللي مشاركين معنا في هذا المؤتمر الدولي لجراحة المناظير النسائية في ليبيا الأول من نوعه. حننتقل معاكم حضورنا الكرام للسيشن 2 أو المحاضرة الثانية مع نخبة من الأطباء. حنبدأ أكيد على طول بالبروفيسور عاطف فزاري، فليتفضل. دكتور عاطف لو موجود معنا حاليا داخل القاعة يا ريت تتفضل. عندنا أيضا الدكتور علاء حامد أو البروفيسور علاء حامد، حتى هو حيكون موجود معنا أكيد في السيشن 2 اللي حتتقدم بعد شوية. أيضا البروفيسور حميدة الجنين فلتتفضل. والبروفيسور غزيل الحداد. حيكون معنا طبعا المتحدث أحمد صابر فليتفضل.
عشان نغمس بقى، انا عايز انام يا عم. السلام عليكم. عادي مش مشكلة. السلام عليكم. انتوا نمتوا ولا ايه؟ كده يا باشا. عايزين نهدي الإضاءة هنا شوية. زي الفل.
عاطف فزاري، بروفيسور عاطف فزاري.
السلام عليكم.
دي واحدة يا أحمد هقدمك الأول. يعني الراجل دكتور أحمد صابر أو بروفيسور أحمد صابر من الناس البايونير في اللاباروسكوبي. عمل بصراحة هو أكتر واحد تعب من يوم ما احنا جينا، يعني ما قعدش. احنا بنروح على الأوتيل، شفنا حالات ونروح على الأوتيل وهو بيكمل. امبارح مروح الساعة 4 تقريبا الفجر. وطبعا ده انا قصدي في الناس المصريين. طبعا الدكتور ابو دبوس اكتر واحد تعب في المؤتمر ده من اوروفر بقى، ليبيا ومصر ومن كل حته. فدكتور احمد صابر من الناس البايونير او من الدكتورز البايونير في اللاباروسكوبي، وعنده سنتر في مصر كبير جدا. يعني اي حد بيأتاتش للسنتر ده طبعا بيستفيد كتير. هي will represent المحاضره ايه يعني احمد بقى؟ التكنيك to reduce blood loss during laparoscopic myomectomy. اوكي اتفضل.
كم حد من الحضور حاول يتعلم مناظير؟ طيب وكم واحد عرف يتعلم مناظير؟ مفيش خالص؟ حاولتوا كلكم، حاولتوا بس ما وصلناش لحاجه. ان شاء الله باذن الله. احنا جينا هنا عشان خاطر اخواتنا وزملائنا في ليبيا. دكتور محمد ان شاء الله هيبقى نيوكليس لنشر الادفانسد لاباروسكوبيك سيرجري في ليبيا ان شاء الله، ويساعدكم كلكم ان شاء الله. واحنا جايين بدعوه منه، وربنا يوفقه يا رب ان شاء الله، واحنا كلنا معاه. احنا النهارده اشتغلنا في العمليات في سنتر مصراته. احنا بقى لنا 3 ايام بنشتغل. دكتور محمد احنا انا وهو عملنا ديلي تيستنج للاوبراتيف ثياتر. اوكي، انتوا عندكم هنا امكانيات جباره. احنا النهارده اتحرق مننا 3 آلات ليجاشور جديده لانها راكبه على جهاز غلط، والجهاز الصح موجود في المخزن، فدي كانت مشكله. المهم فالتكنيكال ايرور او المشكله اللي حصلت انتر اوبراتيف النهارده احنا حاولنا نتغلب عليها، لان احنا قابلنا مشاكل مشابهه. احنا زيكم، احنا نفس البلد ونفس الوطن ونفس كل حاجه ونفس الظروف ونفس كل حاجه. كويس؟ فاحنا مرينا بمشاكل مشابهه، مرينا بتكنيكال ايرورز مشابهه، واتعلمنا ازاي نتغلب عليها من اساتذتنا. واهم حاجه تساعدنا ان احنا نتغلب على تكنيكال ايرور تو ديفلوب ا تيم. ده اور تيم ان ايجيبت. معانا منه الدكتور مستر محمد فكري، دكتور احمد عزام، وفي مجموعه ثانيه. وفي I believe in to be a member in a successful team is better than to try to develop a new team. تمام؟ طبعا انا اشتغلت وانا مطمن لان ماي منتور الدكتور عادل موجود، واخويا وظهرنا هنا الدكتور محمد ابو دبوس. فكنت شغال اكني شغال في المركز بتاعي، ما حسيتش باي فرق خالص. المشكله اللي بتحصل قصه ان في لايف سيرجري وفي ناس بتتفرج، ولايف يعني مش اللي قاعدين بس بيتفرجوا، لا في ناس في مصر بتتفرج، ناس فولورز بيتفرجوا. في مشكله حصلت انتر اوبراتيف، المشكله دي بتتمنتج في الفيديوز. انتوا على طول بتشوفوا فيديو متمنتج، يعني مش اللي انتوا بتشوفوه على الفيسبوك ده الحقيقه كامله، ده جزء منها، ده اللي انا عايز اوريهولك او اللي انا عايز اوريهولك. لكن انتوا النهارده انتوا شفتوا لايف سيرجري، ريال سيرجري من العمليات. من الحاجات المهمه طبعا احنا ده تيم واحنا شغالين. ده امبارح الساعه 4 الفجر احنا مخلصين عمليات في مصراته 4 الفجر، وجينا 7 الصبح كملنا. دكتور محمد ابو دبوس ربنا يديله الصحه، ما اعرفش هو يعني متحمل ازاي كل هذا العبء ده، واحنا بنعمل تشيك امبارح بالليل، رغم ان احنا عملنا تشيك على كل حاجه، مفيش حاجه نو ديفايس نوت تيستد يسترداي، بس برضه قابلنا مشاكل وقابلنا تكنيكال ايرورز، وطول ما انت بتحاول تشتغل هتقابل مشاكل. المحاضره سريعا كده how to make the field of myomectomy bloodless. Myomectomy is a bloody operation. Even in open surgery, it is a bloody operation. Prevalence of myoma, anatomical considerations, the uterus has double blood supply from uterine from the internal iliac and ovarian direct from the aorta. Indications of myomectomy, imaging and classifications. Our presentation now is to assess the preoperative measures and intraoperative measures. Prevalence, it is the most common benign tumor, female pelvic tumor. About 50% of the patients of uterine myoma are asymptomatic. We have different indications of myomectomy. The most common is abnormal uterine bleeding, pelvic pain. صوت يا دكتور. Pelvic pain and infertility and recurrent miscarriage. في other indications like compression, manifestations, broad ligament compressing the ureter, making hydroureter, and so on. But this is the most common indications. Anatomical considerations about the blood supply. To make the field bloodless, I will try to occlude the uterine artery and ovarian artery, but the problem is we should not occlude it permanently. But when the myoma is present, ده الاناتومي بتاع البلاد سبلاي to the uterus, internal iliac، بيطلع من anterior division uterine artery، بيروح بيدينا ده الاركيد فيسلز. الاركيد فيسلز penetrate the myometrium via radial vessels. All this architecture is distorted if the myoma is present. يعني لو انا هفتح الكبسول بتاع الميوما او هعمل هيستروتومي انسيجن مش هتفرق افتحها بالعرض ولا افتحها بالطول as regarding blood loss. انا هختار الانسيجن of the uterine wall according to the port placement. Okay, you plan the operation. I will incise the uterine wall transversely. I will suture from 2 ipsilateral and so on. 2 ports ipsilateral. In presence of myoma, the radial vessels distorted. All the architecture within the substance of the myometrium is distorted. This is a diagram demonstrating that. What are limitations of laparoscopic myomectomy? مين اشتغل laparoscopic myomectomy؟ كم حد اشتغل laparoscopic myomectomy؟ Okay. في other limitations other than these 3 limitations. الايه؟ Space for manipulation, size of the myoma. Okay. Size of the myoma may be a limitation for the decision to do it laparotomy. More than 10 still debatable. How to minimize the blood loss? Specimen retrieval still debatable, especially Karl Storz stopped morcellator production. Chinese make other copies and suturing. The debate only due to lack of suturing skills. Hemorrhage, it is the main problem during myomectomy. How to estimate blood loss during laparoscopy? All the time you will tilt your head towards the suction to see the amount of the blood aspirated. Measures to decrease blood loss, it may be preoperative and intraoperative measures. Preoperative, patient selection is very important, patient preparation, hemoglobin content and so on. good imaging to plan your operation and to select port placement and select all the procedure. Preoperative interventions, uterine artery embolization, vaginal misoprostol, GnRH agonist, and GnRH antagonist. Imaging, value of imaging before doing myomectomy, choose approach, number and location, laparotomy or laparoscopy. Above 10 centimeters myoma, the debate may be decreased. Above 10, I may shift the case to laparotomy. Even I do a case 18 centimeters and 20 centimeters, but is not the usual. Okay, not the guidelines for that. A number more than 3, in my opinion, more than 3 and sizable myomas, better to be done laparotomy. Surgical planning other lesions, if the myoma associated with other lesions like endometrioma, I think the plan and the counseling of the patient will be different. Decrease recurrence and avoid missing of myomas. كم حد اشتغل laparoscopic myomectomy ولما دخل انترا بروتونيال او بعد ما عمل نيو بروتونيال وشاف اليوترس قال where is the myoma? After inflation, where is the myoma? حد مر بالتجربة دي؟ After doing pneumoperitoneum and entering the peritoneal cavity, where is the myoma? Right or left? Especially if associated with adenomyosis, which make the uterus bulky, where is the myoma? Right or left? مرينا بده. أنا أعرف ناس مرت بها في الأوبن سيرجري. Methods transvaginal sonography مشكلة بتقابلنا في الفيرجنز. I believe that the MRI is the gold standard for diagnosis. MRI, especially in virgins. Transrectal ultrasound, how can transrectal ultrasound diagnose or plan the surgery for the myoma 15 centimeters? مع transabdominal, مع transrectal, but MRI is still the gold standard. Especially it can differentiate adenomyosis, local adenomyosis or adenomyoma from endometriosis, from myoma. This is different pictures, shows the value of MRI, precise sizing, especially MRI with contrast. Relation to the endometrium is very important. And numbering of the myoma. This is the common figure classification from 0 to 8 classification. I should classify to choose the approach. How can I remove the myoma either by hysteroscopy, by the expert Dr. Munir, or by laparoscopy? Preoperative medications. We have GnRH agonist for 4 to 6 months. Common Zoladex, احنا بندي Zoladex subcutaneous for 3 to 6 months. It make a pseudo menopause and cause the myoma to be shrunken. But it makes the surgery difficult because the pseudo capsule or the cleavage plane between the uterine wall and the myoma is lost. So extraction or inoculation of the myoma will be difficult. Also, if we use GnRH agonist for a long time, small myomas will shrunken. I cannot detect it intraoperative if present. So I don't recommend using GnRH agonist for that. And the main value of GnRH agonist is to improve the blood hemoglobin preoperative. البيشنت اللي هي عامله قبل كده عندها myoma. The main complaint is abnormal uterine bleeding and menorrhagia. Some patients come to us with a hemoglobin 4 or 5. So GnRH agonist long acting may add value to improve preoperative hemoglobin. But it does not decrease the time of his operation. Preoperative uterine artery embolization, I have no experience with this technique, but it is not recommended in patients which seeking fertility, as some reports about the decrease in ovarian reserve after preoperative uterine artery embolization, and it is done immediately preoperative at the morning of the operative procedure, but I have no experience for that. Intraoperative measures we have pharmacological and non-pharmacological agents. واحنا شغالين بقى دخلنا بطن العيانه وابتدينا ننفخ وشغالين. هنعمل ايه intraoperative؟ Drugs taken intraoperative pharmacological like vasopressin, neurotonics and tranexamic acid. اكيد كلنا عارفينهم ما عدا الفازوبريسين. الفازوبريسين is not commonly present in the market, but in Egypt we have vasopressin, and in my center I have a large number of vasopressin ampoules. Neurotonics, either prostaglandins, oxytocin, misargine, methyl ergonovine may have a role, and non-pharmacological temporary closure of the vasculature supplying the uterus. Pharmacological عندنا الفازوبريسين. فازوبريسين من الحاجات الجميله جدا جدا اللي احنا بنستخدمها في before myomectomy. Mechanism of action of vasopressin, vascular spasm and causing myometrial contractility, half-life 20 minutes, but it is not recommended in cases which have cardiovascular problems, and still not FDA approved for this purpose. But if you try to inject some drug intramyometrial, it is better to use vasopressin. Dilute vasopressin over 100 milliliter saline. Each 100 milliliter saline contain 4 units of gliapressin or vasopressin. But before you inject the vasopressin intramyometrial, you should pull back the plunger of the syringe, not to inject it sinusoidal or in a large vessel, intramyometrial vessel. Epinephrine not recommended. Uterotonics, misoprostol may have a role. I think يعني مش ما فيش مشكله ان احنا ندي ميزوبروستول بيفور ذا اوبريشن، يعني حتى لو احنا هنديه مع الفازوبريسين دي اي حاجه مش مشكله يعني. Still the dose is not precisely the effective dose, and does the dose is related to the size of the myoma or not? Still studies not sufficient. Oxytocin, debate about how it act on non-pregnant uterus. It is commonly act on pregnant uterus. And finally, the methyl ergonovine, highly effective during uterine myomectomy. Methyl ergonovine infusion intraoperative may add value. Tranexamic acid taken according to body weight, 20 minutes before incising the uterus. I may give the patient tranexamic acid, but the patient with history of thromboembolic events should be excluded from this criteria. Non-pharmacological, we have a tourniquet. It is very difficult to apply the tourniquet during laparoscopy. Very difficult. And the idea of tourniquet is to be intermittent. You cannot do that every time. في other methods to occlude the uterine artery like shoelace knot and application of a bulldog clamp. Tourniquet, it is very difficult to apply it by laparoscopy. Temporary ligation of the uterine artery at its origin using a removable shoelace stitch. This is a bulldog. Maybe النوع ده بيستخدم في الاوبن سيرجري، بس في نوع لللاباروسكوبيك سيرجري. Operative tricks. Laparoscopic port placement is a very important trick to decrease blood loss. You can do suturing in 20 minutes and the other can do suturing in 3 hours. أكيد اللي بيشتغل في 3 hours blood loss هيبقى more than اللي بيشتغل في تلت ساعة. فده مهم جدا في الكرايتيريا. Uterine incision مش هتفرق أعمل uterine incision transverse or vertical as the blood supply is distorted in the presence of the myoma. Good port placement, adequate incision, rapid suturing, rapid technique, decrease blood loss. The most famous method to close the uterine incision is a continuous inverted baseball stitch. Baseball. في some videos. عايز اعمل ايه؟ افصل ازاي البرزنتيشن؟ This is a large myoma. You should take a panoramic view. Where is the tube? To see how to do. Temporary closure of the uterine artery in such a case is very difficult. to reach the pararectal space or paravesical space to occlude. We will apply the bulldog at the IP ligament. Still, not sufficient studies about closure of the ovarian artery by removable bulldog. But it is better, the time to inoculate the myoma is not more than 20 minutes. This is a normal saline, injection of a normal saline. You will see that the field is nearly bloodless. Nearly bloodless field. I prefer to use a advanced bipolar or even conventional bipolar for releasing the myoma from its capsule. Some fine attachments between the myoma and the uterine wall. Nearly bloodless field. This is a probe used not to broken the instruments. This is the final view. This is suturing of. We will not tie the knot first. We will tie the knot after we return. We will take the deep layer. Then I will tie a knot anterior. Then I return to tie the final knot at the end. This is 2 knots only used for closing the uterine defect. This is the pistol, inverted. In, out, in, out. Port placement is very important in managing these cases. Okay. Assistant, Mr. Fikri, trying to assist me. Better hemostasis, this method, and this is the final note. This is a free tail of the thread. When you pull on this side and this side, you will make as a purse string. شايفين؟ Okay. Transverse matrix يعني ممكن تحسن الموضوع أكتر يعني. نشوف بقى فيديو للشو ليس ستيتش أو شو ليس نوت. This is application of the bulldog over the uterine artery using right angle. Identification. احنا النهارده شفنا اليوتراين ارتري عند الاوريجن في الحاله اللي حصل فيها هو نفس الحته دي كده وبنحط فيها البولدوج بدل ما بنعمل له كاجيليشن بنحط بولدوج اهو زي ما انتم شايفين. نحط بولدوج بعد ما بيخلص اناكيليشن ويخلص العمليه بتاعته بيشيله تمام او بنشيله. ده عندنا شوليس هنفتح السبيس. We will create the space and reaching the uterine artery at its origin. ليها طريقة أكيد كلنا بنربط الشوز بتاعنا هي نفس الفكرة. إحنا ما بنربطش شوز بيرمننت صح؟ نفس الفكرة. بنidentify اليوتراين artery. ده ال internal iliac. هو 2 screws only. هنعمل نفس الكلام على ال other side بالظبط. ده ال other side. Incise nearly bloodless field. شايفين الميوما تقريبا ما فيش blood loss. ده temporary closure of the uterine artery after inoculation of the myoma remove the shoelace or the temporary knot. شايفين الفيلد nearly bloodless. نفس الكلام عملنا اللي هو ال continuous inverted baseball. نشيل بقى عادي خالص اهو شايفين. removed. Okay. The same in all videos. This is a case of previous myomectomy done by open surgery. I don't recommend in small myomas or even in large myomas open surgery because it make a very.
Ahmed, time is over.
نعم.
Professor Ahmed, time is over.
تمام يا باشا خلصت. شكرا يا جماعة، أنا آسف على الإطالة وشكرا جزيلا لكم.
Thank you for your nice presentation. Well done, really.
شكرا.
And now we'll open for discussion. Any question for Professor Ahmed?
بلاش بقى، بلاش احنا حبايب بقى.
Can you tell me if there is any difference between your endoscopic tower with nice imaging and our tower today? Is there any difference between the imaging? Because I can see here
Karl Sturz Spice image 1S. All the tower is Karl Sturz.
That means the quality of the endoscopic tower for today's.
I think Olympus Karl Sturz is the best.
Okay. The myomectomy.
The quality of image is a very important point in any surgery.
Yeah.
Main value of laparoscopy is panoramic view, magnification power, good imaging. This is the power of laparoscopy. If you lose this,
I ask this question because I know that you face a big problem today and last night by imaging by.
It is not a problem. It is a challenge. We build up an experience. We build up a new idea. Yeah, this is a challenge, and we will deal with any challenge for success for this conference. Challenge.
Good. At which number you are stopping doing laparoscopic myomectomy? I mean, not the size, because I think every size is suitable for myomectomy, but which number? You are saying
after 15 it is difficult to do. After 15 centimeters it is difficult, but I do more than 15.
شكرا محمد. Yesterday it was red, but today there was the nurse who was trained for the setup of the tower. Yesterday we worked with the red image, but today it was perfect with striker. So it's a matter sometimes just for sitting. So شكرا حبيبي محمد على المحاضرة الجميلة. I want to give some messages. The first one is pre-operatively we should differentiate sometimes adenomyosis because it can be very difficult and a lot of bleeding.
You need harmonic.
Yes. That's the first thing.
If you don't have harmonic, you cannot do adenomyoma. Very difficult.
And the second thing, I tried everything for methods to decrease the bleeding, uterine artery ligation. The most important message to the audience is to know the real anatomy. There is the myometrium, then the capsule, then the myoma. If you are between the myometrium and the capsula, you will have bleeding. If you are between the capsule and the myoma, that's the right plane to be in. That's the first message. And whether we do saline or other things, the result is the same. So I do only saline to prevent other side effects of other drugs. So if we do the aqua dissection and we put a lot of water saline to aqua dissect the myoma from the capsule, not the capsule and the myometrium, we are totally bloodless. And to do that, you should not hesitate to go until the myoma, not the capsule, because sometimes we are, the message is not to be over the capsule. We feel sometimes that we are in the good plane, but we have to go more deeper. That's the second message. And the third one, if at all we have bleeding during the enucleation, sometimes we can have the feeding vessel that we cut, because there is always a feeding vessel. What I do always when I do the enucleation is the U-stitch. A new stitch is an hemostatic. I start by doing a new stitch. At the same time, we do a good hemostasis. After the U-stitch, nothing bleeds. And also to not have a dead space, because you can have a bloodless surgery, but complication post-operatively in
This
obstetrical
dead space
matter.
may collect blood and make internal hemorrhage later on. Dead space closure of the dead space is very important. After we do suturing and closure of the incision of the myoma, لو انتوا لاحظتوا هتلاقينا خدنا ترانسفيرس ماتريس على السبيس كله، يعني سكيورنج يعني. طب نعم. Time depend on the experience.
كم؟
Depending on the experience. يعني النهارده في اللايف سيرجري احنا التايم بتاع التراين ارتري لايجيشن اتس اوريجين اقل كتير جدا 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 من التايم اللي احنا حاولنا نعمل بيه كواجيليشن للتراين ارتري عند الازمس. تمام؟ it is depend on your experience. how
prolonged الوتي
during the inoculation only, inoculation time of the myoma and remove it.
عندي سؤال
تفضلي.
about uterine artery embolizations before surgery.
I have no experience about uterine artery embolization. This is interventional. I have no experience about this.
Okay.
Do انت قصدك حضرتك اللي هو الهايفو والكلام ده ولا مش فاهم؟ إيه السؤال؟
I think you're asking the implication of uterine artery embolization on doing myomectomy.
During a myomectomy,
I have good experience with it because I get several of cases. It makes it really varies. It can make it extremely difficult. It can make it very hard. I have seen cases the embolization causes a fibroid to degenerate and become too soft. That can make the dissection very hard because every time you try to dissect the fibroid from the myometrium, it breaks. Another change, it can make calcification around the fibroid and the center is degenerated. So morcellation will be very hard to do the calcification part, and the inner part will also break in small pieces. The third is the ischemia caused by the embolization will cause the fibroid sometimes to make very vascular connections to surrounding structures in the abdomen, and that's how the fibroid will regrow again after embolization. And then you come and find the fibroid attached to vascular adhesions, to the sigmoid mesentery, to small bowel, to even the stomach. I had a case to the stomach, which is very vascular, and that can make the procedure very hard. That is why I'm very anti-fibroid embolization.
أستاذي
سؤال شفت حالات قبل كده يوتراين ساركوما؟
uterine sarcoma. حالة واحدة.
Diagnosed as a case as a uterine fibroid by ultrasound, by MRI, and discovered the post-operative accidentally as a uterine sarcoma.
This is a present instance.
You found this
open,
case?
not laparoscopy. Old age patient about
Not old age, young age.
No young age. I have no experience.
I have seen 2 cases.
Laparoscopy or laparotomy?
Laparoscopy. I
This is
don't
an
talk about
instance.
laparoscopy or laparotomy. I asked about because you will see. Yes, prediction.
Totally diagnosed preoperative as uterine
yes,
leiomyoma.
Female patient. I have 2 cases.
histopathology.
Female patient, 35 years old, with 1 offspring. Okay, by MRI and ultrasound. I am routinely doing MRI pelvis with contrast routinely before any myomectomies.
I agree.
Okay. By MRI with contrast, the diagnosis was iotine fibroid. But intraoperative, I'm suspecting sarcoma.
دكتور احمد دكتور عادل, what about the medical legal aspect if we
ما انا بتكلم على كده بقى.
if you did morcellation and then discovered that this myoma is myosarcoma,
ما انا بتكلم
what is the medical legal aspect?
The medical legal aspect is a great matter of counseling.
What?
Counseling before any procedure. The patient should know that. Counseling. يعني احنا
what did you say in counseling?
لا ما انا ما شفتش حالات زي كده.
What did you say دكتور عادل in
شاف حالتين هو الباشا اللي يقول.
It's very important.
The first case, I remember the first case about 5 years ago or 6 years ago.
The case in USA.
ما انا هقول لك.
It was a Egyptian doctor. Bad luck. She went from Cairo to live in USA, and she had the myoma. When we morcellate the myoma to discover that it's a myosarcoma. It changed the morcellation of myoma. What's the medical legal aspect now? If I do morcellation,
your experience, Dr. Adel, your experience, how to counsel the patient after you detect sarcoma.
How you suspect sarcoma intraoperative? This is the main question for.
Okay.
حكملتها لاباروسكوبي ولا؟
Because sometimes by ultrasound and by radiology, 100% uterine fibroid final diagnosis, and intraoperative you have a suspicious criteria for uterine sarcoma. Number 1 is highly vascular. Okay. Number 2 is there is no plane of dissection. If you have no plane of dissection between the uterus and the fibroid. Number 3, if you have an infiltration of surrounding. Number 4, if you have a small nodules over the uterus or peritoneum.
What will you do? Intraoperative.
I will shift to open. I will take a frozen section. We have a frozen section in my hospital. I remember in one case, the first case I found it, I take the decision while the patient is on a side and I do hysterectomy. And the patient seeking for fertility. And I do hysterectomy without consent.
Depending only on frozen section?
Yes, I take frozen section. I know this is a medical legal is wrong.
Yeah.
But the patient pre-operative is confident and say to me, up to you,
do what
you see intraoperative. Once I suspect, I turn it to open, and my assistant said to me, no, I turn it to open. I said to him, I'm suspecting sarcoma in this patient. I take frozen section, a part of this nodule, frozen section. The frozen section said to me that the sarcoma, I do pan-hysterectomy for the patient. And after recovery from anesthesia, the patient come to me and say, thank you, Dr. Adel, you have...
سايبين لنا حاجة أنت يا دكتور عادل.
So this is how can you suspect? This is very important because you will do morcellation. If you do morcellation and post-operatively the sarcoma, medical legal is wrong.
Okay.
Even
that's
if you take a consent from the patient.
This is a message to stop laparoscopic myomectomy at all.
You want me to say something? Okay. Well, there is no precise prediction of myoma or myosarcoma. We have to say there is no precise prediction, and this is how to counsel patients. It's completely hard for women to hear that, but it's impossible to predict precisely it's a myoma or leiomyosarcoma, and it's very hard for pathologists to say to tell during frozen section whether it's precisely benign or malignant. And we usually do not perform frozen section. We have the opportunity, but it's completely problematic for the pathologist, and I mean the consequences are very severe. And the problem is, in my opinion, the problem is not morcellation, because think about what happens to patients with leiomyosarcoma. They will suffer from hematologic metastases, not from intraperitoneal metastases. That's a problem, and it's completely unimportant if you morcellate or not. If you keep the uterus, this will be the death palm for the patient. this will be the problem, keeping the uterus. Nevertheless, you do it open or laparoscopically. So in case of leiomyosarcoma, the only sensible operation is hysterectomy, but we don't know it. So in the younger patients, it's in all cases in our department, all cases, it was a surprise. Usually we thought we are going to operate myoma, and the pathologists said no, it was a LMS. It was always a surprise. There's no real suspicion.
What is about the medico-legal aspect in such cases? This is a question of Dr.
Can I just comment on this?
Salam. Thank you. Thank you. I'm sorry to stop this nice discussion, but we have to move to the other speaker, our Prof. Munir Mustafa, cesarean section niche, view from within, one of the pioneer in hysteroscopy.
Laparoscope. Good evening, everyone. Good evening, everyone. I'm Dr. Munir Mustafa. I'm a dedicated hysteroscopist since like 7 to 8 years. Today I will be talking about a very important topic, which is cesarean scar niche. It's a very common pathology. Everyone in the outpatient clinic of gynecology and everyone working with infertility has been involved in the management of cesarean scar niche. Everyone knows what cesarean scar niche, but everyone has a different idea what is a cesarean scar niche and what's the management of cesarean scar niche from the other one. This is due to some differences and some conflicts in the literature. But the literature is upgrading very, very fast. Since few years, I started to collect all the data, collect the expertise all around the world with the help of the ISGI, the International Society of Gynae-Endoscopy, to try to make like a kind of formal guidelines starting from the definition, diagnosis, and management of this pathology. A picture of the final data has been just presented a few months ago, and I'll try to show you what is the real pathology behind the cesarean scar niche. قلنا كفايه لابروسكوب. Okay, do you want it in English or Arabic? English, okay. أسهل بالعربي. فرانكو عربي. خلينا نبدأ. Yes. جزء the major amount of information we have, the recent ones, is due to doing hysteroscopy in the cases with cesarean scar niche. That's why the presentation is called View from Within. We are changing the way of our understanding to the pathology using the hysteroscope before the step of management. The term itself is cesarean scar niche defect, isthmocoel, diverticulum, pouch, and others are used in literature in the same way. They all have the same meaning, and the definition is the presence of hypoechoic area within the myometrium of the lower uterine segment reflecting a discontinuation of the myometrium at the site of previous cesarean section. That means the diagnosis of cesarean scar niche is an imaging diagnosis, an ultrasonographic diagnosis. When you see the patients, you see the complaint, you make the management, you see the outcome, you will find that these definitions, they neither meet the clinical findings nor guide through the management. A lot of patients, by the ultrasound, by definition, she has a niche. We undergo hysteroscopic surgery. The symptoms improve. The patient may get pregnant. Then when she repeats the ultrasound, you still find this thing, and the ultrasonographer write niche. So we will go through this, but let's have some numbers as an introduction. It's found in around 50% of post-cesarean sections among literature, starting from 18 to 80%. We have literature saying that 18% of patients post-cesarean have cesarean scar niche. Other papers stating numbers up to 80%. It's probably a cause of secondary infertility. For laparoscopic suturing, which was once thought the golden standard of management, we have recurrence of symptoms up to 40% after 3 months. Okay. There are a lot of theories about the etiology. We don't know exactly what's the problem, but any malpractice inside the cesarean section, any complication increases the rate of the niche. If you have a lower incision, if you do the cesarean during active labor, this is cervical causes. If you have tension on the wound, malapposition of the wound ends, endometrial involvement in the suture. If you have suturing material, if you suture single layer or locked sutures, if you have adhesions in the operation, if you have inadequate homeostasis or infection, and patient-specific factors. Still, there are many groups around the world working to know what is the main cause of niche, but it already occurs in some rates. They don't know what's the problem. The definition we have been seeing is it's a multi-aspect pathology. It starts as a malhealing. This is just the beginning, that the cesarean section wound doesn't heal well. It ends in anatomical disruption and local reaction presenting with a spectrum of symptoms. The new term, just few months back, is cesarean scar disorder, not cesarean niche. Cesarean niche is going to be used for the ultrasonographic findings, but it itself is not now a pathology. The new term is cesarean scar disorder, and to differentiate it from the cesarean scar defect, which is CSD also, we write it CSDI. Okay, let's see now in depth what is the anatomy of the cesarean scar disorder. First thing, you have, this is the cesarean scar. You have malhealing in the mucosal side. So first thing you have is the defect. And this is what you see by the ultrasound. And every scar has a defect. This is not a pathology. This is the residual myometrium. This is the part of the myometrial thickening above the scar. This is the niche. The niche is the geometric part of the cesarean scar disorder, preventing fluid in the defect from getting out easily. Then this is the healing surface where the healing of the wound should occur. So cesarean scar disorder, the pathology is, we have many pathologies in this place, not only the niche. We have the scar's thickness. We will see every one in details. We have the niche, we have the chronic infection, we have the malhealing process, we have the endometriosis, local endometriosis, which is adenomyosis, and we have the uterine malcontractility. First thing is the scar thickness. This is the residual myometrium. It has to be measured during ultrasonographic examination. This carries an obstetrical risk of wound dehiscence or rupture uterus. We don't know what's the exact cutoff point that below this number, below this value, it has to be sutures, but it is around 3 millimeter 4 millimeter, 3.5, 2.5. There are a lot of numbers. I think 3 millimeter is the median of what's published. Worldwide, the incidence of cesarean scar in the cervix is 10%. But what I see in most of the countries I go, Arab countries, I think Libya is like them, about 70 to 60% of the scars are cervical. When you go in the hysteroscope, you go through the inner external os, you go to the cervical canal, you see the scar, then you see the internal os. So if the scar is lower, is it safer for regarding uterine rupture or not? There is no literature about this. Okay. The second pathology is the niche. The word niche itself means the ability to retain. It is the shelf. It is the part that collects the menstrual blood in the defect. And the pathognomonic symptom is post-menstrual spotting. It has complications with IUI because sometimes the catheter hits the upper part and goes inside the defect. In the embryo transfer, the same thing, and I saw some patients with the IUD inserted inside the defect rather than inside the cavity. It also may retain an embryo, ectopic pregnancy. This is different from the scar pregnancy. So the cesarean scar niche, cesarean scar disorder is the niche plus symptoms. So if the ultrasound finds a niche and the patient has no symptoms, this is not a pathology. This is not a cesarean scar disorder, and she doesn't need management for this particular thing. Okay. Now this is how we see the niche in the hysteroscope. We have a lot of imaging we'll see later, but we are here for the hysteroscopy. You see, this is it. We have here some bubbles going inside the defect. If you can't see the bubbles inside the defect, that means there is something between you and the inner surface of the scar. This part is the part that prevents fluid from getting out. Collection happens, mucus, infection, inflammation, and post-menstrual for 5 or 6 days, you see this view. Now we are going inside the uterine cavity. This is the cervix. You have persisted mucus, brown. It's coming from the defect inside. You see, this is the mucus plug, this is the brown mucus plug. It's very thick. And when you finish the operation, you find it coming from the vagina, a very thick, big part. Now we should put, yes, see? We have a lot of videos. Now the third pathology is the chronic inflammation. Not all niches with retained fluid causes inflammation, because inflammation is caused when the retention is prolonged. And the patient starts to complain from discharge, not only post-menstrual spotting. Some patients complain of only post-menstrual spotting, which is small niche collecting little fluid, blood coming out after the menstruation, then everything is okay. But for prolonged retention, you have chronic inflammation. You will have discharge, pain, dyspareunia, inflammatory polyps inside the defect. You have sometimes cervical adhesions, infection, chronic endometritis, and progression. This is something recent. The chronic inflammation here will eat the tissue around and will create the bigger defect, bigger niche, and it may affect the posterior wall of the uterine or cervical canal. It is a state similar to hydrosalpinx in the effect of chronic inflammation. This is how the chronic endometritis look. Diffuse hyperemia, stromal edema. See, it's not fresh micropolyps, micropolypi. You feel micropolypi all around. Strawberry sign. This is, of course, infertility case. The fourth pathology is the healing surface, the healing process. Vessels are coming to this area are coming to the wound to supply blood for the healing process, but they don't find tissue. They become subserosal or submucosal large vessels in the air, and they start to bleed, and they cause abnormal uterine bleeding, like this video. See, this is the defect. We don't have a big niche, but we have big vessels inside the defect. They came for healing process, but they didn't find tissue. In this patient, all we have to do is to coagulate the blood vessels, but we don't have a real niche to remove. The fifth thing is the endometriosis or adenomyosis, the chronic presence of menstrual blood inside the defect. With the inflammation, they invaginate inside the myometrium walls and cause cysts of adenomyosis. This causes dysmenorrhea, of course. This is examples. When during removing the niche, we see collections of adenomyotic tissue. Adenomyosis in hysteroscopy are black or brown spots, like this one. You see, we removed the niche up, but there is collection bringing out endometriotic discharge. You see it? This has to be cleaned. This is deep inside the wound. The last and the least available literature is the effect of the scar itself on the total contractions of the uterus. Some patients, they don't have blood inside the niche, they have blood inside the cavity. And there was no satisfactory explanation for this. But now there are at least 3 theories. One of them is that we have something called the uterine contractility cycle, that the uterus itself contracts downward in the follicular phase, stops during ovulation, then starts to contract upward during the luteal phase. During the upward contraction, the cut of the scar, the Zenic scar, stops the pulses and makes like a constriction ring. It's an element of obstruction in the cervix, and this leads to collection of the fluid or blood in the uterus. Another thing is that the fibrosis of the scar itself with the niche affecting the posterior wall all around the cervical canal causes partial obstruction to the cervix, collecting fluid up. Recently, one of the laparoscopic surgeons, he found that this upper part of the niche can act like a valve and close the cervical canal, making the fluid to collect up. This part closes it like a valve. It's mobile. One minute. Time? 1 minute?
10 seconds.
You saw this? Okay. Let's jump to the hysteroscopic repair. It's a resectoscopic operation. We don't use the regular hysteroscope. It's a matter of resection. You have to resect this part. This is the latest type of operation. We have many operations by the hysteroscope. This is the more common and the best one. You have to resect the lower edge of the niche and coagulate all the inner defect wall. It's a remodeling. It's defect remodeling. After the operation, you will not remove the defect. You are just remodeling the defect to avoid collection of fluid. That's why the ultrasonographic definition doesn't apply for this. This is not a symptomatic treatment. Now, this is a definitive treatment. This is how you insert the resectoscope. You put the loop inside the defect and start cutting until there is no hidden parts of the defect. You don't augment the scar. After, in the operation, we don't build up we don't suture the scar, but we don't make the scar weaker. Once you remove the niche, there is no collection. But still there is a defect. This is very important. This is how you see the hidden part during the diagnostic hysteroscope at first, and this is how you see the repaired without a hidden parts inside the defect. Okay. I think let the video at the last. So this is a fast chart for those who are in the gynecology OBD. If the patient comes with a cesarean scar disorder, if she has a complaint, and if she has a complaint, now we call the symptoms cesarean scar syndrome. If she's complaining and not seeking conception, this is for hysteroscopy. We are not afraid of obstetric complications. If she has complaint and she's seeking conception, now we have to measure the residual myometrium. If it's less than 3, you have to make suturing. We have many techniques of suturing: abdominal, laparoscopic, transvaginal. If more than 3, then she is for hysteroscopy. If she has no complaint and seeking conception, but the residual myometrium is still less than 3, then you have to make suturing. Okay. So the only limitation of resectoscope or hysteroscopic management is the residual myometry. We have more good news. Just a few months back also, the post-operative morphological changes of isthmocele after the complete resection with the resectoscope and coagulation of all the inflamed tissue, 3 to 4 months later, you find that the residual myometrium could increase from 40 to 100%. So because you remove the infected tissue, the healing process resumes and the residual myometrium could increase. We have two publications about this point. This is not still anyhow an evidence to make hysteroscope for patients with residual myometrium less than 3. Okay. خلاص ولا? Just one last thing, you have been seeing me using one tool only to repair the niche. I said it's a resectoscopic operation, but which resectoscope? We have 5 in gynecology. We have 5 sizes of the resectoscope. The smaller 3 are called mini resectoscope. Why they are called mini resectoscope? Because we don't need to dilate the cervix to insert them inside the uterus. And these are devices of choice. Because if you dilate the cervix, as I told you, many of the niches are cervical. You are masking part of the niche, and you are changing the default shape of the pathology. Later, if you dilate the cervix, you go into with a big resectoscope, you remove the niche, and you finish, it's okay. But when the cervix becomes normal again, you will find the niche is there. Bipolar is more safer than monopolar. Bipolar wherever available. Bipolar is not available everywhere. If you use monopolar, you use cutting current, not coagulation, cutting current. The lower cutting current that makes the job. Okay. Take-home message. Caesarean scar disorder is a compound pathology. It may present with a variety of symptoms. Hysteroscopy is not the golden standard of diagnosis because you have to measure the residual myometrium. Intraoperative diagnosis is not uncommon. Many patients come with different pathologies, and when you go with the hysteroscope, you find the niche with or without the pathology. Many times the caesarean scar with the blood collected is diagnosed as endometrial polyp. Suturing is a standard technique, but not always the best. Hysteroscopic intervention is excellent in correctly selected and evaluated patients and is gaining more popularity. pathology understanding, patient assessment, and treatment, knowing the treatment options gives you the best outcome. Thank you.
Thank you, Dr. Munir. Thank you. We'll open for discussion. We'll take one or two questions because it's time for lunch. And they are waiting us for lunch. We'll come back and finish this, the session. Any question? Yes.
My question, since you said that the pathognomic picture of niche is the post-menstrual spotting. Once I have lady with post-menstrual spotting, can I have any benefit of timing of day 2 ultrasound? It's help or not? This is my question. I mean, if I specify the day of doing ultrasound, can help me to diagnose the niche or the defect of cesarean scar before I proceed to hysteroscope for diagnosis?
You don't diagnose by hysteroscope.
Yes, before that.
If she's a previous cesarean lady
Yes.
with post-menstrual spotting, for me, I proceed to the hysteroscope. Because if she doesn't have a niche, she should have another pathology causing this bleeding. Hysteroscopy is the procedure of choice in all abnormal uterine bleeding.
So timing of ultrasound, there is no benefit, yani?
I don't depend on ultrasound a lot. And if you tell the patient, if you tell your ultrasonographer that this patient is previous cesarean, or I think she has a niche, she will tell you she has a niche. As you see, the definition of niche is very superficial. Yes. It's hypoechoic area of 2 millimeters. Any scar in the world will have a 2 millimeter defect.
بس هو دكتور منير بيقول هو he doesn't rely on ultrasound a lot. هو مش هيدخل يعمل حالة فيها سيزيريان سكار نيش إلا لما يكون عامل لها التراساوند وشايف الريزيدوال اندوميتريوم الريزيدوال مايوميتريوم.
In diagnosis, not an assessment. In diagnosis, not an assessment.
In diagnosis is a part of assessment. Okay, thank you. Go to lunch.
دكتور معلش أنا عندي سؤال على risk of perforation with treatment of niche with hysteroscope. There is risk of perforations. How we minimize it?
For all hysteroscopic operations, you have risk of
but I think it is more because the myometrium is very thin in the niche.
3 millimeters. This is not thin because the loop itself, the diameter of the loop is 3 millimeters. So